yeah, first time in front of an audience, for a real audience for 18 months. It's really, what a pleasure compared to being in front of a screen. And actually the first time I've given a lecture about this interface between FND and MS. And I was thinking how, what sort of patients are we thinking about here in your practice as MS nurses? And I think it's those patients who you know do have MS, but their disability is a lot worse than it should be. I think that's the group I'm talking about. There are other intersections that are important here, so intersection with chronic pain, chronic fatigue, and other psychiatric disorders. But I'm going to specifically be talking about MS today. Sorry, about FND. And I think FND, because you can make positive diagnoses, is particularly important in terms of being able to start to get some inroads into, as I've said in the title there, looking for a potentially treatable cause of disability in MS that's not MS. So I've some conflict of interest. I was asked to put a slide about there and let you have a look at. There's nothing there specifically MS related or related to pharma. So why do we need to think about FND and MS? This is Lorraine Kelly, who you recognise is the patron now of FND Hope UK, which is great. She got to know some younger people with FND and sort of recognised how ignored it was and how difficult it was for people often to access treatment. I think it's probably an under-recognised comorbidity, particularly in mild MS and early MS presentations. We're recognising that it's a common comorbidity of most neurological conditions, in fact. And it's a potentially treatable condition. I think we should be thinking of functional disorders as a bit like looking for B12 deficiency or thyroid deficiency. You don't want to miss it because it might be something that is impacting a lot on this person's disability. And the treatments we're learning about FND, they are different. They have fundamental differences to how one might approach, for example, disability from MS, particularly things like physiotherapy, and I'll come on to that later. So let's just start with a case. This is Lucy. And Lucy was interesting because, like many, you often think people with FND, they've all got a lot of psychiatric problems, or they've had childhood abuse and things like that. They don't. Many of them do, but many of them have not had any of those things. Lucy was a businesswoman, and she came onto this Radio 4 show to tell her story. So if we can run the audio clip there.
Car. Basically, I'd woken up in the morning and I'd had a mild sensation of numbness in my face, but just assumed I was tired and didn't think anything of it. But by dinner time, my daughter, who's 10, had looked across and said, you know, Mum, are you okay? Because my whole face had drooped on the right side, and then became aware that my right arm wasn't functioning either. And my husband, of course, panicked and called an ambulance, and they took one look and said, you know, you've had a stroke, we're taking you into the hospital.
So this was a sort of stroke-like presentation. About half of patients with FND causing weakness will have these sort of sudden stroke-like presentations, and about half have a more MS-like gradual onset, in fact. Show me your teeth. So this is Lucy's face down the line. Just try and keep your mouth in that position and then relax. That does seem to have made it a little bit worse. Now, she was thought to have facial weakness. Can you feel the contraction?
Yeah.
Just show me where you feel it contracting.
I feel it here.
Yeah.
And then it starts to come down here.
Yeah. So it wasn't actually facial weakness. It was this positive feature of FND, which is contraction of platysma. And you can do that yourself if you contract your own platysma. It makes your jaw go off to one side and your lip curls down a bit. Now that just happens to be something that really mainly only happens in FND. It'd be very unusual to see that in another scenario. So it's an example of a physical sign that tells you this patient probably has FND. And I'm going to show you more. And that's really important when you're dealing with comorbidity, because how can you tell if someone's disability relates to FND unless there are clear positive features of it? So contraction of platysma like that, or sometimes people have sort of scrunch up their eye on that side, and it looks like weakness, but it's actually muscle overactivity. And she also had this sign, which I'm going to show you next, which is Hoover's sign, which I think is one of the most useful signs, both in diagnosing but also in explaining to patients that some of their weakness is due to a disorder of nervous system functioning rather than damage. And it's weakness of hip extension. And I know that you're perhaps thinking, well, I don't make these diagnoses, but I think everybody, if you're dealing with FND, it's really useful for everyone who's working with a patient to understand these signs and potentially to be able to show the patient the signs, because there's nothing more convincing to a patient than to actually see the way that these things have been diagnosed and what they mean. So let's see Lucy's Hoover sign. Press this heel into the ground as hard as you can. And it's normal. So she's got normal hip extension on that side, but this is weak. That's weak. Okay. And then, which is unusual for most neurological conditions. Yeah. Stop me from pressing down. Hip extension weakness. Focus on that leg. Really, but when I lift up her other leg, the right leg becomes normal. You can feel that the right leg returns to normal. So there's a difference between, in FND, what you're seeing is a difference between the voluntary movements, which are impaired, and often you get that sort of give way and jerky, collapsing kind of weakness, but the automatic movements, which are normal. So that's telling you this patient has a disorder of voluntary movement, but it's a kind of higher order disorder of voluntary movement because the automatic movements are normal, so it can't be due to damage in the nervous system. So Lucy had FND, she didn't have a stroke, she had several normal scans, but that wasn't why we were making the diagnosis. She could have had MS, mild MS, she would still have had FND with those signs. And she didn't need psychological therapy, she needed explanation, physiotherapy, and she did well with that. So I've recently been exploring this clinical overlap with MS with a guy called Andrew Solomon who works in Vermont, who's written a lot about misdiagnosis of MS. There's been actually, this is the first article, I think, really to start writing about this formally. And we tried to bring together what we know. I think it's fair to say there's a lot we don't know. There's not been an area where people have been doing research, partly because of how FND's been considered. If you want to have the article, you can point your phone at that and it'll, or on the recording, and it will give you a download. And some other resources for FND generally, again, if you wanted to point your phone at that after today. And so the whole world of FND's changed a lot in the last 10 or 15 years. We have a international FND society now, which is multidisciplinary. It's become a much more legitimate scientific field, I would say. So FND is a common disabling condition. It's a diagnosis of inclusion. It's not a diagnosis of exclusion. You can make it in someone with MS, and that's one of the key features here. Although sometimes they are mistaken for one another. Probably more often, patients with FND are diagnosed with MS than the other way around, but we don't really know for sure. So let's have a look at some of these things. Common and disabling. Well, functional disorders, in a broader sense, so FND is one type of functional disorder, are really common. They're so common that actually if you're sitting in this audience, you've never had a functional symptom or heading towards a functional disorder, then it's a bit weird. Most human beings have functional symptoms of some kind to varying degrees. But they're somehow weirdly ignored by training, by textbooks, by curricula, because they're disorders that you can't see on a test. And then people wonder, is this really a thing? Well, it is a thing. And it makes up probably around 30% of all secondary care, primary care consultations. So it's a massive sort of ignored, it's a massive blind spot of medicine, really. In neurology, functional disorders are the second commonest reason to see a neurologist after headache, and you can argue about headache and migraine, about what kind of disorder that is too. So some more positive signs, and I really want to show you these today, just to give you an idea of what we're looking for. This next clip shows Rachel, who's a university student, had a right-sided hemiparesis. She's got a slightly clenched fist, which you see is something called functional dystonia, and you'll see here a test called hip abductor sign. So can I just get you to push against my hand here? We can see when we do that, you're stronger than I am, and I can't push that knee in. And then let's try and do the same thing with this knee, so stop me from pushing in. Push out as strong as you can. But I'm winning there, pushing your knee in. Let's go back to this side. I want you to push out again as hard as you can. Really stop me. Push, 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 push. Now when we do that, we can see that actually what's happening over on the right side is that it's become much stronger and I can't push the knee in now. So it's brought out the automatic movement. So it's the same principle as the Hoover sign. These are diagnostic signs that they were sort of floating around when I was a trainee, but they were barely written down anywhere. In fact, various neurologists came up to me and were worried that I was starting to write about them because they said, well, the patients will find out. And if the patients find out, then they won't have them anymore. So which tells you something about sort of attitudes towards this disorder. Patients do not lose these signs if you show them to them. And as you can see, one of the things I think that's really turned around here is this ability to show patients the signs and say, look at that potential for improvement you've got when you're not focusing on the limb. There's something wrong with your brain in that the more that you try to make the movement, the worse it gets. And that becomes very important when you're thinking about things like physio. So, and this chap has got functional tremor. You can see it's pretty disabling.
86.
He's doing some mental arithmetic, but it's not really making much difference. But as soon as he's asked to copy a movement, this is a really simple test, just copying a movement that the examiner makes, which is then speeded up and slowed down, you can see his other hand has become much better, and at times it's entraining to the same rhythm as the examiner. So that would be a positive feature of FND causing tremor. And here you can see, as he makes the movement, just briefly pauses. So shaking, stops, starts again, stops, starts again. So that's pausing with ballistic movement. So it's just an example of how you can identify functional tremor. And of course, a lot of patients with MS have tremor. This is a very straightforward test to do. If you think your patient might have FND, why not do it and see? If they've already been diagnosed with FND, you might be able to show that sign to them and help them to understand that there's another mechanism going on here to explain at least some of their symptoms. This is a man who went really round the houses with this gait disorder. And you can see it's an unusual gait disorder.
Okay. So I'm having to think through what it is I'm trying to do as opposed to just doing it naturally.
So he's having to think through. He's thinking too hard about movement, not in a voluntary way. But as soon as he does this sort of pretending to ice skate type of movement, his gait becomes much better. And also walking backwards is a lot better. Try and walk backwards towards me.
So walking backwards is the one which is really weird because it's not really natural.
That's something I normally do, walk backwards, no.
Yeah, okay.
But no, that was a bit of a revelation, to be honest, because I'm not having to think about it and just do it.
Yeah. So that's what we're trying to do in FND, is give patients that sense of revelation that there is a potential for difference in the way that their movement can be. Obviously, you can't sort of go around walking backwards the whole time. But actually what we discovered with physio was that he could run much better than he could walk, which sounds a bit mad, but it does make sense with FND. He had a corruption of his walking forward program, but his walking backwards program was okay. He was interesting because he was, as you can see, he's a sort of middle-aged man, he's working, and I think his diagnosis was delayed because people were not thinking that someone like that could have FND. I think you see underdiagnosis in that group, sometimes see overdiagnosis in different groups like younger women, for example. So you do not have to decide between FND and MS. When I was younger, we had these games, I think they're still around, top trumps, where you're kind of comparing things like cars and stuff like that on sort of criteria, and then one card would be better than the other. I think it's fair to say if FND was a card in a packet of top trumps, it would be the absolute bottom card that nobody wants to get because its features are just not very popular. And there is a tendency for people to think, oh, someone's got a disability, you've got to decide what it is. Is it FND or is it MS or not MS? Well, it could be a bit of both. And that's where I think we could be missing potential for treatment. So let's just think about a story. This is a patient, sort of précis of a patient of mine who was sent to me from the MS clinic. She definitely had MS. She had a typical MS scan. She had some signs of a hemiparesis with a bit of spasticity, but she was really disabled. She was in an electric wheelchair. And the neurologist said, look, I think this disability is worse than it should be from what I'm seeing. And she had multiple positive features of FND. Now, initially, she was very kind of reluctant to be told that she might have another condition causing a disability. It was a bit of a threat to her identity. FND is not a difficult thing to explain sometimes, or people take it the wrong way. But for her, it was incredibly useful because in the end, she was working through with the physio. She realised that some of her weakness and disability was FND related, and she got to the point where they were looking at her ankle dorsiflexion weakness, and the physio said, oh, actually, I think this is probably MS related. And she was actually really disappointed that it wasn't her FND, because if it had been the FND, then there's greater potential for improvement. So she went from being essentially using an electric wheelchair most of the time to being able to walk with one stick and go down to the bottom of the garden. So for that individual, this particular comorbid diagnosis was really helpful, pointed her towards improvement. We've got very little data about what this overlap is, how many people with MS have functional symptoms or excessive disability that might relate to a functional disorder. This is a study we did in Edinburgh. It's pretty rough and ready, to be honest. It's just looking at new neurology outpatients, and neurologists were rating how much of the disability related to that diagnosis. And you can see it was about sort of 10-15% in most groups of neurological conditions. You were looking at patients where the neurologist would say, well, they do have Parkinson's or they do have MS, but I'm not sure that their disability is completely explained by that. So it might be something about that. There's been another study in Germany recently finding these positive FND signs in about 7 or 8%. So it's not that common, but it's common enough to think about as a comorbidity. And if you add that to other comorbidities like pain and fatigue and psychiatric disorders, you're looking at quite a big group probably. So what is FND? Is it a psychological problem? What is it? And I just wanted to say a little bit about this, because this is a disorder that when I started training over 20 years ago, it was viewed as entirely a psychological problem. It was almost, it's still got, in fact, a Freudian label of conversion disorder, the idea being that patients have some sort of stress and they're converting it into a physical symptom. Well, I think we've been able to demonstrate that is, although not entirely untrue for some patients, it's a much too narrow model of this disorder. And this is a multifactorial disorder, like most neurological conditions. And one of the strongest risk factors for FND is having another neurological condition. So if your body is going wrong because you've got MS, then it can make the software of your brain go wrong as well, because it's very disconcerting when things are going wrong. So I don't really have time to go in detail, but this is the sort of model that we've got. So we've got predisposing factors, which include other functional disorders, adversity, other medical conditions, stressful life events. And typically then patients will have a triggering event, which is often actually more pathophysiological. It might be an injury, migraine, something like that. Much more common than stress to actually trigger the initial symptom. I think Lucy, who I showed you at the beginning there, her trigger was probably a migraine. She was knackered, she was working too hard, she was a bit zoned out, she was having a migraine, and then things just sort of got out of hand, really, and an ambulance was called. There wasn't a kind of major life event going on for her at that time. So for most people who have those vulnerabilities and triggers, they just recover, they just get on with it, and things don't escalate. And FND happens when people enter that sort of spiral of worsening symptoms, a bit like, and acutely that has a lot of parallels to panic attacks. And then a lot of comorbidities, which often get confused with the underlying core disorder, but are very common, like depression and anxiety. So you don't need to have a psychiatric disorder to have FND. And then all sorts of things go wrong for these patients once they have these problems, because they're in a healthcare system that doesn't recognise their condition, or tends to disbelieve them, or says, I don't know what to do with this. This is not my job, or this is a psychiatric problem, but the psychiatrists say, well, we don't know what to do either. So that's where we are, I think, with this condition. And stress is part of that, and adverse experience. And we've shown, this is a Lancet Psychiatry review, just showing that adverse experience is much more common in these patients at a rate of about 3 or 4 times population. Not that different to people with depression and anxiety, to be honest. So it is a risk factor, but it's a bit like smoking and stroke. You know, lots of people who've had heart attacks or stroke are smokers, and it's relevant, but there's quite a lot of people who haven't been smokers, and we shouldn't be insisting that everyone must have been a smoker. And is the brain relevant? Yes. What other organ could it be coming from? And we are learning more about what's going wrong in the brains of people with FND. This may not look very impressive. This is functional. This is fMRI, showing an area in the right temporoparietal junction that's not working very well. Now that's a node in a network related to agency, so the parts of your brain that tell you that it's you doing the movement that you're doing. And some evidence that that network's not working very well. And kind of what the patients are telling us, it doesn't feel like them that's doing it. They're not in control of their movements. But in relation to a functional disorder of the nervous system rather than damage. So I've talked about comorbidity, but just thinking about misdiagnosis, this does happen. This was a patient that I saw recently who was a very acute patient. I saw her in A&E. She had left leg weakness, numbness. She had a very clearly positive Hoover sign at presentation, but there were also some other bits and pieces which did suggest that she might have another neurological condition. But it did look a bit like FND, but we did the scan, of course, and she had MS. And when I saw her a couple of weeks later, the Hoover sign had gone. And I think it was just a feature of her acute response to having that weak leg. So that's a very acute misdiagnosis. You do sometimes see chronic ones, but I think they're much less common these days because people do get MRIs quite early in most cases. So people with MS often have traditionally gone on a journey where they've been misdiagnosed with other things, not infrequently. And it seems that about 1 in 5 of those things that they're misdiagnosed with when that happens are FND and other functional disorders based on our review. But the data is very variable. I think this happens more often. So this is a patient I saw who for 10 years had a diagnosis of MS. She was actually running an MS group and was using a wheelchair. And when she saw a neurologist again after many years, examined her, said, well, actually, I think this is all FND. And her scan was sort of non-specific high signal, which is often the issue. So she actually did, like the other patient, did very well with treatment, and her mobility improved a lot, but actually this was very difficult for her because MS was her identity, it was her role. And we didn't actually, it was difficult to know whether to take that diagnosis away completely. She was really angry. She was angry that she'd been misdiagnosed, but she was angry because someone had just given her the wrong label. It's a bit like if someone came up to me and said, John, actually, you're not a doctor. We've made a horrible mistake. You've got some other kind of job, and we've just got it wrong. And it might be a perfectly good job, but it's not the job I thought I had. So we've got to be very careful how you undiagnose people, I think, in this situation. Ultimately, she's glad she was undiagnosed, and because she accessed the right treatment, but it wasn't easy. And so they've called it conversion disorder here. And fibromyalgia is another functional disorder, and some of those other categories are probably functional symptoms as well. So I think it's one of the leading causes of a situation where someone has just got the wrong diagnosis. So just finally, I'll just talk briefly about treatment. So people say, oh, it's tricky to explain this diagnosis, it's all a bit complicated. What about Freud and conversion disorder? I don't think it is that hard. You just have to treat it like any other condition. I treat it a bit like how I would explain MS to somebody, to be honest. So what you don't do with MS is just keep doing tests, hoping to get the answer. The tests are important, but actually this is not a diagnosis you make because a test is normal. It's because the patient has the signs of FND. And this goes wrong a lot. I mean, this is a bit different in the context of MS because you're saying to a patient, well, you've got two things wrong with you. But this is often how things go in general neurology. People are told what they don't have, which isn't that helpful, really. When you've got a weak leg or tremor, you want to know what you do have. Or they're told that they've got a stress-related problem. And I think that's a bit like saying to someone lying in a trolley in A&E with a stroke, saying, I know what's wrong with you. I know why your leg is paralysed. It's smoking. And you just wouldn't say that because you're jumping to the sort of etiology before you've even explained well, what it is or how that's relevant. It might be true that their leg is paralysed because of smoking, but that's a bit of a jump. And these are the sort of responses that patients have. When you talk about stress causing a physical symptom, can you think of any celebrities who have what might be thought of as a psychosomatic condition? There are none. I mean, we have celebrities with mental health problems now, so that's becoming a bit better, but celebrities with psychosomatic problems, no, they don't exist. People think of it as something that is being made up. So what to do instead? Well, just treat it like any other condition, very straightforwardly. If you're talking to someone with MS, well, you've got MS, but it looks as if you've got FND as well, and that's important because there's a potential treatment attached to that. And they'll say, I've never heard of that, and you have to sometimes be clear that it's a real thing. And showing their patients these physical signs, as I've explained, is the most useful thing I think that I do. That's often the light bulb moment. Patients tell me, when I ask them, how did I help you? They say, it's when you showed me that sign. Then I really understood why you were saying what you were saying. Because it shows that something in their body and brain is potentially reversible. And it's a software thing rather than a hardware thing. And maybe we can give you some rehabilitation that retrains the brain. So this is a website that I've made recently upgraded to help people understand FND better. There's an app now for it, which hopefully helps people access information more easily. And I like to physically hand people fact sheets about this so that I know they've got the information. This one I particularly recommend for your patients with MS because they're most likely to have limb weakness. And I direct them to specific information on the site. And we now have these patient charities and people like Lorraine Kelly. So the tide is turning very slowly, but I think we've got a long way to go with this disorder. And then thinking about other treatment, I've said, well, are other treatments different? And physiotherapy is particularly important here because, and Glenn Nielsen's led on this, Glenn's a physio in St George's, to show that actually the treatments that seem to help most are ones that use these diagnostic signs, use this principle of the automatic movement being normal and the voluntary being impaired, which means you do different things than you would normally do. Because if you've got someone with a stroke, you might get them to think really hard about their leg. But what I've shown you is that when these patients think hard about their leg, it makes it worse. So they're actually better having treatment that helps them focus on a different body part. And this is a patient who's got functional leg weakness. And he's really relying heavily on his crutches. Lost all confidence in his legs, really. And this is Audrey and Melanie, physios, treating him. And they're doing subtle things here, like initially there's a weight-bearing grip in his right hand. But Melanie changes that to a non-weight-bearing grip. They might be getting him to listen to some music or distraction. And you do sometimes get these kinds of results in FND. I'm not saying this happens all the time, but it does happen. And so what we're looking for is that sort of change in somebody who might have MS as well. Now, I'm aware of time, so I might just, this time I'll skip through that's another video. Or should we show some video? Okay, all right. Right, okay, well this is a great video. So this is Miranda, who's
as well.
We'll just pause a second.
Because
So Miranda's a primary school teacher in Australia, and she got FND, a functional gait disorder, and this is a video, a film that her uncle took about her. So it's just a couple of clips from that. So if we play this one.
In some regards as well, because I tried to have a positive attitude for a lot of it, but when you just don't seem to be making any progress, and I didn't feel free. I felt very, very trapped in hospital. It was really amazing when I could run again.
I have never seen someone like Miranda before. And even though she could not walk or she could not even stand by herself, I took up the challenge to put her on the treadmill.
My mum was there filming at the time, and she thought that it was crazy. And then he just made it faster and faster, and that's when we discovered that I could run. I could go quickly, but not slowly.
So that's similar to the other guy I showed you, isn't it? And so that was a kind of revelation for her. And then so she could run, but she couldn't walk. So the physio had her gradually slowing down her run to try and regain normal walking.
That was what really got me going. If I can run, I can figure out how to walk. And that's when we really started getting innovative. We realised that I needed to retrain the way that I was thinking. I left the Royal Brisbane and went to a rehab unit in the hope that I would just one day just walk, but we had no idea how long it would take. And eventually that's just what happened.
Do it again for me.
Sam and I, we were in depth conversation, and then it wasn't until we were halfway down the street that we both realised that I was walking like normally.
That is a miracle.
And my biggest fear then was to stop walking. I just kept walking because I was like, if I sit down and stop, what if I can't walk again?
So it's a really nice story. You can tell this lady really did have that problem, and she was so delighted when it improved. And it improved at a moment when she was deep in conversation. She wasn't thinking about her walking. So that's sort of principle of the treatment. And those kinds of treatments have been tested here in London with Glenn Nielsen leading, and do seem very promising for these patients. This is a feasibility trial of 60 patients, and currently Glenn's leading a trial of about 300 patients across the UK. So we'll have more evidence. We've produced these occupational therapy consensus recommendations recently. OTs are in a brilliant position to help these patients. They have skills of sort of physical and psychological treatments, so we think they have a big role to play. And this is brand new speech and language therapy recommendations as well. So there are resources out there to try and help people manage their FND patients better. This is one about psychotherapy, which I haven't had time to talk about, but obviously is very important in the treatment as well for many patients with these disorders. So you can't help everyone with FND. Just because, I certainly don't want to give you the impression just because you've diagnosed FND that they will get better, or that bit of their problem should get better. It's often the case that it doesn't. These are often chronic conditions that are hard to treat as well. So here's some conclusions. FND is a diagnosis of inclusion, not exclusion. We can share all this in a very transparent way with patients. We don't need to do what has been done before and keep it all secret. I think it remains to be seen, I think, how many people with MS might have functional disorders and what kind of potential there is for reversibility. And the models we have now of both what's causing this and treatment are now much more interesting, I think, than just a narrow psychological view. And they include the brain, they include multidisciplinary treatment. So I will stop there, and I've been going with my clock here, which says I've still got 7 minutes, but I don't know how things are looking time-wise. But here's my group. I just want to tribute to my group in Edinburgh, which is a very multidisciplinary group, as indeed it should be with this disorder. So thanks very much.